Well, good evening, everybody. We'll be respectful of everybody's time and go ahead and get started tonight. Tonight's guest speaker, it needs no real introduction. Dr. Jonathan Abelson is well known to the Colorectal Education Series as a founding member, of course. He completed his residency at Cornell in New York City for general surgery, and then went on to do a colorectal fellowship at Washington University in St. Louis. He's currently assistant professor and staff surgeon at Lahey Hospital Medical Center. Tonight, he's going to talk to us about a very important topic for general surgeons and colorectal surgeons, of course, and that's the evolution of rectal cancer treatment. Thank you again, Dr. Abelson, for your years of hard work in creating this series and for joining us tonight to give us your talk.
Great. Thanks, Rishi. All right, so we'll talk about the evolution of rectal cancer treatment and why we do what we do where we are now. So a couple of just sort of disclosures here. Let me get this. Where am I? Yeah. So, you know, this all sort of stemmed a little bit from how I decided to do my learning and fellowship's nearly over for you guys. But I just sort of took notes on my, cloud, on my iPhone, on my iCloud, and, had that with me in clinic. And then, that way I could just sort of easily refer to things. And so started sort of keeping track of all the important trials in rectal cancer. And as I was in clinic with, all the attendings and residency, it was sort of like, what numbers am I going to quote to people? And so that was really something that I tried to focus on a lot in training. And so far in the first 18 months of practice is, when you're sitting there in the room with the patient, what numbers are you going to be quoting? So as we sort of go through this, that's one thing that I would just sort of impress upon you is to think about, what are the numbers that you want to quote your patients? So ton of studies, and I'm just sort of going to paint some broad strokes. We're not going to dissect each and every article. It's an evolving topic. A lot of slides, going to move through a lot of them very, very quickly, just to sort of paint some big pictures. As we go through some of the studies, I'll just point out a few things about, sort of how they did their inclusion criteria, exclusion criteria, how these trials are designed, what the outcomes are. So those will be a few things that you'll sort of make note of, and I'll sort of point out. So we'll just sort of skip to the end. So what are we going to cover today? So the treatment of rectal cancer has evolved dramatically. We used to do just surgery alone. Then we did surgery with radiation therapy or chemotherapy after surgery. Then we started doing radiation therapy before surgery, followed by chemotherapy. Then we started doing total neoadjuvant therapy and then surgery. And now we're introducing this fun topic of watch and wait. TNT really probably is the preferred preoperative treatment of choice for all locally advanced rectal cancer. And I think patients and fellows and staff need to be aware of the watch and wait option and sort of know how to counsel patients. So start with a case. So this is someone who I saw in clinic. So 65-year-old obese, a lot of comorbidities. And in 2015, when I was just a wee general surgery resident, she had a stage 2 low rectal cancer. She got long course chemoradiation therapy and then got an APR and had a pathologic complete response. And so that's, great prognostic information. Everyone's jumping for joy. That's fantastic. However, in part due to her obesity and comorbidities, she had stoma retraction and she had 3 reoperations. She went to a local wound care clinic and they raised concerns about her ability to pouch, and you can understand why. So you look at the stoma here, you can't really see it. Fortunately, she was able to keep an appliance on and she was having output. But, we've all sort of seen stomas like this. Thankfully, I will say this was not one that I made, although not all of mine are as beautiful as I'd like them. But then you sort of say, well, what if we told you that instead of getting an APR with a path complete response, perhaps she could have avoided surgery altogether and perhaps would have had no difference in her overall survival. So that sort of lays some of the framework for what we're going to talk about today. So, we'll just sort of talk about the rationale for, why we give chemoradiation before surgery, why we talk about giving chemotherapy before surgery and TNT. I'm going to gloss over most of the operative stuff, and then we'll get to, the exciting, sexy stuff of rectal cancer these days, nonoperative management and watch and wait. All right, so really one of the main studies that everyone really needs to be familiar with, okay, is this trial out of the Netherlands. So that this really established the evidence for giving radiation therapy before surgery. Okay, so again, initially we just did surgery, and then this was one of the main trials that really suggested, okay, we should be doing radiation therapy before surgery. So interestingly, for this trial, I'll just sort of point out a couple things. So radiation therapy was actually short course, and we'll talk a little about that a little bit later. So randomized patients either receiving short course and then surgery, or just surgery alone. I'll skip some of this stuff. Interestingly, in their study, so again, this is published in 2001 in New England Journal of Medicine, they're including stage 1 cancers in there with stage 4. And about 30% of patients have stage 1 cancer. And so we'll see in some of the later trials, we're really just talking about stage 2s and 3s, locally advanced rectal cancer. So we're looking at surgery versus radiation therapy, short course plus surgery. And this is going to be a constant theme with all of our studies for rectal cancer, is really there is no study out there that shows that one approach leads to better overall survival. Okay, so no difference in overall survival. What we do see, and this is really what makes the foundation for doing radiation therapy before surgery, is your local recurrence rate dramatically decreases if you're giving upfront radiation therapy. So 8% down to 2.5%. And then no difference in distant recurrence. And when they looked at their multivariate regression analysis for local recurrence, surgery alone had a much higher hazard ratio for having a local recurrence. Interestingly, one of the other sort of points from this study, and you'll hear some people talk about it, is this concept that radiation therapy is probably not as beneficial for the upper rectal cancers. And so, that's one of the points that I'll make out of this study as well. So these are their conclusions. So short-term preoperative radiation therapy further reduces the risk of local recurrence. So we talked about doing radiation therapy in addition to surgery. Why don't we give it after surgery? And so this, we go to the German Rectal Cancer Study Group. Again, New England Journal, 2004. And everybody's getting radiation therapy in this cohort. In this cohort, it's all long course, so 50-40 gray. But you're randomized to receiving it either before surgery or after surgery. And their primary endpoint, and again, sort of pay attention to what are their primary endpoints, because they differ between studies. So they're looking at 5-year overall survival. And it was designed to show an absolute difference of 10% in overall survival between post-op versus pre-op chemoradiation therapy. I'll skip through some of this stuff. One thing I'll just sort of point out in here, and this is really the basis, I think, for a lot of our neoadjuvant treatment, and really the basis for TNT. When you look at preoperative chemoradiation therapy versus post-op chemoradiation therapy, received full dose of radiation therapy, 92% versus 54%. So that's, dramatic, right? And so if we're talking about, we want to give patients the therapy that they need, giving it to them before they undergo a major surgery is going to be key. Looking at some of the complications, stricture at the anastomotic site, so significantly higher in the post-op radiation therapy group, and this makes sense. You're radiating a fresh anastomosis. Surgeons do not like that. The overall complication rate, no difference. And the anastomotic leak rate, no difference. But one of the really interesting points from this study is rate of sphincter preservation. So these are 194 patients in their cohort, or in their study, determined by the surgeon before randomization that they would require an APR. And in pre-op chemoradiation therapy, in about 40% of patients, they actually did sphincter preserving surgery, compared to about 20% in post-op radiation therapy. So really, bringing up the importance of preoperative radiation therapy for downstaging and potentially allow a sphincter preserving approach. Same concept that we'll see throughout all of our trials here. No difference in overall survival or disease-free survival. When you look at local recurrence, big difference. So 13% local recurrence in post-op radiation therapy versus about 6% in pre-op radiation therapy. And this probably has to do in large part due to 90+% compliance with the intended therapy with pre-op radiation therapy versus about 50-60% in post-op radiation therapy. So if you're not getting the treatment that we know is going to be beneficial, then you're going to have higher risk of local recurrence. And then no difference between distant recurrence. All right, so those are their conclusions. So we'll sort of move along. So what about short course versus long course? So as Rishi brought up, so I trained at WashU in St. Louis, one of the few study centers in the US that exclusively does short course radiation therapy as a standard of care for all rectal cancer. So we got a lot of experience and exposure to using short course as part of a TNT regimen, and we'll look at some of those data a little bit later in this talk. But another group and cohort to be aware of is the group out of Poland. So Poland short course trial published in British Journal of Surgery in 2006. And the rationale they found for using short course is you can have similar long-term survival, local control, and late morbidity between long course and short course. And in their experience, short course radiation therapy is less expensive, more convenient. There's concern about in short course, high dose per fraction raises concern about late toxicity. So they really wanted to compare the two. Okay, so they did a randomized controlled trial of short course with surgery within 7 days versus long course with surgery 4 to 6 weeks later. And so you'll just see even here, we're not talking about any stage 1 tumors. These are all clinical T3, T4. Post-op chemotherapy optional, and they're looking at radiosphincter preservation. So I'll just sort of skip through some of this stuff. So we'll look at, again, overall survival, no difference between the two. Local recurrence is actually significantly higher in the long course chemoradiation therapy, or rather I should say, not statistically significantly higher, but 15% versus 10%. So, you know, by that measure, we can say that no difference in local recurrence because you're getting some form of radiation therapy, which we know is beneficial. And then no difference in disease-free survival, okay? One thing I'll just point out that I sort of skipped over a little bit in this slide. So, you know, pathologic complete response ends up being a marker that we follow a lot for how effective our preoperative treatment is. And you might look at this and say, oh my gosh, short course path complete response is only 0.7% versus chemoradiation therapy 16%. Well, that must mean that long course is more effective. But this is where you need to really remember what the trial is actually doing. So in this trial, you're giving short course and then operating right away. So there's no time to allow for any downstaging. You're going straight to surgery. Hence why you're not seeing a high PCR rate compared to long course chemoradiation therapy where you're waiting 4 to 6 weeks. So just something to keep in mind as we start looking into some of the TNT data. So, you know, with radiation therapy, we know that if you perform preoperative radiation therapy, you're going to reduce local recurrence by at least 50%. Okay, so all of our patients, and so this is sort of old news a little bit. None of us have grown up in the era where we would consider not radiating locally advanced, or we'd consider post-op radiation therapy, but at least you have some of the foundation with a few of these studies. All right, so let's talk about preoperative chemotherapy and start talking about the rationale for total neoadjuvant therapy. So for this, we'll look at the timing trial. Okay, so first author, everyone should be familiar here, is Julio Garcia Aguilar. So he's the chief of surgery at Memorial Sloan Kettering. Very interesting study where they, you know, the rationale for this is that some locally advanced rectal cancers can respond completely just to chemoradiation therapy alone. If you have a clinical complete response, perhaps you're eligible for less invasive surgeries, even watch and wait. Again, this is published in 2015. Response to radiation therapy is time dependent. Longer intervals from radiation to surgery are associated with an increase in the proportion of patients who achieve a pathologic complete response, which is going to be your best prognostic factor for a patient. If you have a path CR, that's the best that we can offer for our patients. And if you give systemic chemotherapy before radiation therapy, has been associated with slight increase in tumor response. Okay, so phase 2 non-randomized open label trial, again, all locally advanced rectal cancers, and they're looking at the proportion of patients achieving path CR, pathologic complete response. Okay, so there is no watch and wait non-operative management in this study. Everyone is getting a surgery, so you have definitive data with path CR, not worrying about clinical complete response. So very interesting study design. So 4 groups. And you're really actually testing 2 different variables in this study. So one variable you're looking at is increasing the time from the end of long course radiation therapy to TME is one variable. And then the other variable is as you're going along, you're giving more and more cycles of FOLFOX. So 2 cycles, 0 cycles and 2 cycles and 4 cycles, and then 6 cycles. So if we just, makes sense, but time from end of chemoradiation therapy to surgery. So group 1, 8.5 weeks, and then group 4, almost 20 weeks. So looking at the path CR rates, and so again, I'll just sort of cue you into some of these numbers. So if we're just doing, chemoradiation therapy and then surgery, path complete response about 18%. Okay, so in that Polish trial, short course versus long course, the number is about 16%. Okay, so you'll start to sort of see these numbers between each of the studies to give you some sense of what maybe the true number is. And then group 4, all the way at the end, so you're getting long course, 6 cycles of FOLFOX, and now your path complete response rate is 38%. So huge, huge difference. And we'll move along through this. Okay, so 38% of patients who receive 6 cycles and chemoradiation therapy achieved a pathologic complete response. And so the concept here is if you can reliably reproduce these findings, then a greater number of patients with locally advanced rectal cancer could be eligible for organ preservation, which we'll talk about later. So, one of the more recent studies that has come out in the world of rectal cancer is the Rapido Trial that everyone should be aware of. So we'll go through this trial perhaps in a little bit more detail. So randomized phase 3 trial, all locally advanced rectal cancers. And we'll see with some of these tumors are really the bad actors. It's not even the T3s in there. These are all the T4s, clinical node 2 positive mesorectal fascia, lateral lymph nodes. These are really the bad actors in this trial. So their comparisons are short course, then neoadjuvant chemotherapy, either Capox for 6 cycles or FOLFOX for 9 cycles, and then TME versus long course, then TME plus or minus adjuvant chemotherapy. So, we've debated this article a lot. I imagine probably some of you have as well. And it's a little difficult to really compare those two, right? You're talking about a TNT with short course versus your traditional long course, then surgery, then adjuvant chemotherapy. And so, yes, it was published in Lancet Oncology in 2020, but when you think about when these trials were first designed and when you're waiting for those results, this is probably over a 10-year time period. And so, late 2000s, 2010, TNT wasn't as big at that point. Timing trial was published in 2015. So I think your standard treatment at that point was long course, then TME, and then chemotherapy. And so now you're bringing in this concept of TNT, which we're all sort of bought into at this point. But at that point, that was experimental. And this is done in Europe. And so, favoring short course compared to the US, where we favor long course. Primary endpoint, so 3-year disease-related treatment failure. So interesting when we sort of think about study design, they weren't just looking at 5-year overall survival. And so they were looking at sort of this composite of local regional failure, distant Mets, new primary tumor or treatment-related death. I'm gonna skip through this a little bit, skip through that. Okay, so we'll go to disease. So this is their primary outcome, right? So disease-related treatment failure. I didn't put a p-value on here, but this was statistically significant. So in the experimental group, 23% versus 30%. And again, because it's this composite, I don't really know exactly what to make of that number, because that number includes several different variables. But in general, the TNT using short course better in terms of overall disease-related treatment failure compared to long course then surgery then chemo. Same thing with distant METs, so significantly lower in the experimental group. And this is really probably the first one that we've talked about so far where there's a difference in distant disease. We've really just seen differences in local disease with or without radiation therapy. And probably the reason why you see a difference in distant disease is because in the TNT group, everyone's getting chemo before surgery, whereas in the standard group, maybe some of them aren't getting the chemotherapy, hence maybe why their distant disease is not as well controlled. You compare that with local regional failure and no difference between the two groups. Why? Because everyone's getting radiation therapy and then surgery. So everyone's doing pretty well from a local regional standpoint. And then again, surprise, surprise, no difference in overall survival between either groups. And I'll skip through that. So we'll look at just path complete response. So experimental group. So short course, then chemotherapy, then surgery, 28% path CR rate, not quite as good as the 38% from Garcia Aguilar's timing trial. And then we look at standard of care. So long course followed by surgery, about 14%. So in that line of mid-teens, right, 14 to 16% for path complete response. So definitely still a lot better if you're getting chemotherapy before surgery. I'll skip through some of this. So I'll just sort of present, and I don't know, I haven't looked to see if any of some of the WashU folks are on, but I'll just sort of give them a shout out that they've published a couple of trials or a couple of studies talking about their short course TNT experience, looking from both an oncologic standpoint as well as a complication standpoint. And I'll just point out that yes, short course radiation therapy is within NCCN guidelines, so something to consider. If you're not exposed to it at your institution, definitely consider it and think about it wherever you wind up for your job, if that's something that radiation oncologists would consider. And there's definitely a couple benefits that we'll talk about. So this is their sort of standard flow diagram of standard chemoradiation therapy, which we know about, and then short course. So they get their diagnosis, 5 days of radiation therapy, recover for a couple of weeks, and then 2 to 3 months of chemotherapy, about 4 weeks between chemotherapy, sometimes 8 weeks between chemotherapy, and then surgery. One of the benefits that they'll talk about here is you look at the time that you need in ileostomy is going to be a lot lower with total neoadjuvant therapy. That makes sense because you're not going to hold the chemotherapy that you're giving to reverse the ostomy. Usually you'll wait for all of that to be completed. So one of the benefits of TNT, whether or not you're doing short course or long course. So I'll just to keep things moving a little bit, skip through some of the details of the results, and I'll just no difference in survival. We'll just sort of go to some of their conclusions. So basically they found higher downstaging with short course TNT versus long course, which makes sense because you're using both radiation therapy and chemo compared to just long course alone. Overall in site-specific recurrences, no difference. Okay, so everyone's getting their radiation therapy, so local recurrence, no different. Really probably the main finding in terms of difference is just less time with a stoma. And I did skip over that, so I'll just come back to that for a second. So months with a temporary stoma, so about 7 months with long course, then surgery, then chemotherapy versus your short course TNT regimen. The other paper that they talked about or published on their experience, perioperative complications after parotectomy. So, one of the main concerns that I think surgeons have is the fibrosis from short course and whether or not that creates a much more difficult operative field compared to long course. So they linked the patients from their database to ACS-NSQIP results and did some chart review, and basically looked at perioperative morbidity. So using Clavey and Dindo classifications, and looked at then OR time, EBL, TME completeness, et cetera. Interestingly, higher acute kidney injury rate in the short course group compared to long course. And I think one of their thoughts is that perhaps by the time they come to surgery, they've already gotten radiation therapy and chemo, and maybe they're a little more worn out than a patient who's just gotten long course. So, no approach is going to be perfect. But that was really the only difference that they found between groups in terms of specific complications. But really no difference in any complication or severe complications. OR time slightly longer in the long course group for whatever that means. No difference in TME completeness or margin status. So, overall, no difference in complication rate, whether or not they're getting short course versus long course. Complete TME rates are similar, and no difference in negative margins. Okay, so at least from their experience, and it's published in Annals of Surgery this past February, safe to offer this as an approach. Then we'll just sort of get into timing of which treatment goes first. So, the questions just keep on coming, and that's one of the things that I actually sort of enjoy about rectal cancer is there are a lot of data out there. There's a lot of different questions and ways that you can tailor it to your specific patient. We've talked a lot about different terminology: long course, short course, TME, watch and wait. We'll talk about in a little bit. The next vocabulary you need to be familiar with is induction or consolidation chemotherapy. When you talk about induction therapy or consolidation, it really all has to do with what's going first, radiation therapy or chemotherapy. And so this is a really interesting trial, again, out of Germany, looking at which one should you do first. So both of them are doing TNT, which I think that the trials and papers we've talked about so far really establish a much higher PCR rate with TNT. And so the rationale for either approach, so induction chemotherapy, so starting with chemotherapy before radiation therapy, you get early systemic treatment of any micrometastasis, and you're not worried as much about compliance in that case because they're fresh. Concern that maybe with induction chemo, you're reducing compliance with subsequent radiation therapy, which we know is very important for local regional control. And maybe radiation therapy efficacy by selecting radioresistant tumor cells. With upfront radiation therapy followed by chemo, you avoid some of those potential shortcomings, but then maybe you're reducing compliance with consolidation chemotherapy. Phase 2 randomized controlled trial, about 311 patients, locally advanced rectal cancers, right? No stage 1s in there like the Dutch trial. And then all patients are getting a surgery, even if they have a clinical complete response. So you're able to know definitively what the pathologic complete response rate. Interestingly, adjuvant chemotherapy was not recommended. Their primary endpoint, path CR. And so based on our prior literature, we know that the path CR rate after preoperative long course radiation therapy is about 15%. And so they hypothesized that TNT could increase that to about 25. So we saw with the Rapido Trial, it's about 28 with short course in TNT. With Dr. Garcia Aguilar's timing trial, it's about 38%. And so their study basically is picking the best sequence, not necessarily which one's better between the two, but what's the pick the winner strategy is what they called it. So these are the flow sheets, okay? And so this is group A, group B, induction chemo, getting chemo first, then radiation therapy, then surgery versus just chemo, radiation therapy, then chemo, and then surgery. And again, just like with the timing trial, we have two variables here. So one variable is time from radiation therapy to surgery, which we know from the timing trial makes a big difference, but also whether or not you're doing chemo first or radiation therapy first. So, none of these trials are perfect, as we're finding. but they all try and answer a specific question to the best of their ability. So I'll skip that. So when we look at complications and compliance, so if you got chemo first, your radiation therapy related toxic effects were higher than if you got radiation therapy first. If you got chemotherapy first, your compliance with chemotherapy was higher. If you got, and then compliance with radiation therapy is going to be lower if you get chemo first. So basically, whichever treatment you get first, less complications, higher compliance. Second treatment, lower compliance, higher rate of complications. And that will be important when we talk about the summary and results. So I'll just sort of point out, I'll skip this slide. So we'll really just sort of get to the path CR rates. So radiation therapy followed by 3 cycles of chemotherapy, path CR 27%, so similar to Rapido Trial. But then when you do chemo first and then radiation therapy, path CR rate only about 20%. So is that just because there wasn't enough time between radiation therapy and surgery? Very well could be. That was a clinically and statistically significant difference between the two. And then no difference between anastomotic leak rate or other complications between the two groups. So their conclusion, so only the group that got radiation therapy first fulfilled that predefined statistical hypothesis of increased PCR. The treatment modality used first will have better compliance and lower toxicity, and surgical morbidity was basically the same and within the expected range. So the conclusions from their study about which one to choose, it depends. What are you most concerned about with your locally advanced rectal cancer? If you're concerned about local tumor regression, ability to have a negative CRM margin, clinical T4 tumors, or you want to avoid an APR with low-lying tumors that are really bulky, or maybe even achieve organ preservation because of higher PCR, then you should do radiation therapy first. If you're concerned about maybe extramural vascular invasion, lymph node positive disease, although their study doesn't specifically look at that, but you're generally speaking more concerned about systemic disease, then chemotherapy first, because you know compliance is going to be higher with chemotherapy first. So I'll talk about this a little bit later, but I would say my just sort of bias at this point, to me, radiation therapy followed by chemotherapy makes the most sense because of more time from radiation therapy to surgery. And so to me, that's probably my bias. And I would say that our institutional bias as well is sort of shifting towards that as well. So this is just a summary of some of the numbers of complete response rates between adjuvant chemotherapy versus TNT. So, the section on surgery, I'll just sort of go through a little bit quicker and really just sort of get into non-op management and watching weight. And, the reason for that, I think, is ultimately at the end of the day, if you do a good TME, it probably honestly doesn't matter whether it's open proctectomy, lap proctectomy, robotic proctectomy. The important thing is a good TME. And so, yes, there were a couple trials looking at open versus lap, the robotic approach, and we'll look at a few of the data points there, but really the main thing is just doing a good TME. And then we'll touch briefly on local excision versus reverse proctectomy. So this is more just to sort of bring up, again, for you all, just sort of reference of what the main trials are. So ACOSOG Z 6051. So lead author was Jim Fleshman, who some of you know well, published in JAMA 2015. And interestingly, in the exact same issue, the a la carte trial out of Australia, again, lap versus open. So a really special edition of JAMA in that in 2015. But basically both sort of looking at lap versus open. The ACOSOG trial, non-inferiority trial, so trying to prove that lap is non-inferior to open. Primary outcome, composite of CRM, distal margin without tumor, and completeness of TME. And this is an interesting discussion if you're able to pick his brain about, using just a single outcome versus a composite. So I'm going to skip through some of the detail here. Again, if we went through in detail all of these studies, we'd be here for hours, and that's not necessarily the point of this. But basically what they found, overall surgical success measured by a negative distal and circumferential radial margin and complete TME was higher in the open resection group versus the lap group. And so laparoscopic resection failed to meet criteria for non-inferiority for pathologic outcomes compared to open, and potentially inferior, which is interesting, right? Because we're all, everyone's learning minimally invasive approaches and lap approaches and robotic approaches, but at least according to this trial in 2015, it was not non-inferior, yet the advances keep coming. We look at the follow-up data from this study, so published in Annals of Surgery in 2019. So now looking at disease-free survival and recurrence. These were not, the study was not powered for looking for a difference for disease-free survival and recurrence. But now we actually look and see what are the results. Again, no difference in disease-free survival between lap and open at 2-year and 4-year follow-up. Lap did not increase the risk of recurrence compared to open. Any recurrence, local recurrence, distant recurrence, the only thing that predicted higher risk of that of local recurrence, of disease-free survival, is that higher composite score, or that issue with circumferential radial margin, distal margin, positive, and completeness of TME. So if that composite output was not favorable, that was the only predictor of having a worse disease-free survival. So that sort of comes back to do a good TME. So their conclusion, so laparoscopic resection was not significantly different based on disease-free survival and recurrence. Okay, so these results are reassuring for patients undergoing prostatectomy. It's now also apparent after multivariate analysis that the positive CRM is the most important factor in the composite score of an unsuccessful operation. So pay careful attention to your CRM. Again, the other trial to just be aware of, the a la carte trial. So again, same issue of JAMA, this one coming out of Australia. And same thing, lap versus open, same non-inferiority trial, also looking at a composite of oncologic factors, and successful resection defined as complete TME, clear circumferential radial margin, and a clear distal resection margin. I'll skip again through some of the details just so we get to the conclusions. Their conclusions, non-inferiority of laparoscopic surgery compared with open surgery was not established. Okay, so same as the other trial, yet we still do it, right? Although the overall quality of surgery was high, these findings do not provide sufficient evidence for the routine use of laparoscopic surgery. Longer follow-up of recurrence and survival are currently being acquired. So it's just, it's interesting. We do these studies to look for a difference. Or to look for proof that yes, we should continue doing something. We don't get the proof, and yet we keep going, we keep doing it. In the surgical trial world, we're talking about the ROLAR randomized control trial. Okay, so now we're looking at robotic assisted versus conventional lap. So another one of the trials to be aware of, published in 2017 in JAMA. Primary outcome conversion, right? So definitely a different proposition here when you're looking for an outcome, conversion, not this composite outcome and completeness of TME. It was powered to detect a reduction in the conversion rate from 25% in conventional laparoscopy. That was based on the classic trial to about 12.5% in robotic assisted lap group. And then, yes, looking at postoperative complications, and then, are you able to really see those hypogastric nerves so you preserve sexual and urinary function? So I'm gonna, again, skip through some of the real details, but we'll just stick here for just a second. When we look at conversions, 8% in the robotic group, 12% in the conventional laparoscopic group. And really the only predictors of difference in conversions are going to be male versus female. So males are going to have a significantly higher rate at 12% versus female 5%, and then obese versus normal weight. Not surprising. So obese conversion rate 23%, normal or underweight only about 7%. So we'll skip to some of there, and then no difference in groups with respect to bladder function, sexual function. So this is something I think for ongoing studies. So their conclusions: no statistically significant difference in the rates of conversion to open for robotic assisted compared with conventional lap. No differences in CRM positivity, complication rates, quality of life at 6 months. Insufficient evidence to conclude that robotic assisted surgery compared with conventional reduces the risk of conversion. Yeah, we all still can't wait to hop on the robot and do some proctectomies. And then the other trial I'll just sort of touch on for everyone to be aware of, ACOSOG 6041, looking at local excision for T2N0s for organ preservation so that you're not doing a proctectomy. Okay, so again, first author you'll notice, and everyone should be aware of, Julio Garcia Aguilar. And so local excision alone for T2N0, high rates of local recurrence, inferior survival compared to a proctectomy. We know that in locally advanced rectal cancer, neoadjuvant radiation therapy can be very successful in terms of reducing the risk of local recurrence. And there were a number of case series that reported low rates of local recurrence in some select patients with T2, T3 rectal cancer receiving radiation therapy before local excision. So that was basically what this trial looked at. So non-randomized phase 2 trial, clinical stage T2N0 distal rectal cancer, getting radiation therapy and local excision. And so then looking at 3-year disease-free survival in that cohort. They looked at quality of life and bowel function, which you would sort of think would be a no-brainer, that if you still have your rectum, you would have better bowel function. But, these patients are also getting radiation therapy, which has its own effect on bowel function, and you're getting a local excision, which certainly if it's a distal lesion could potentially have some short-term complications. The 3-year overall disease-free survival for patients with T2N0s who are getting radiation therapy and local excision, about 88%. So pretty good. 3-year overall survival, 96%, pretty good. And at the end of follow-up, 91% of patients receiving radiation therapy and local excision had rectal preservation, which again is quite high compared to everybody just getting a proctectomy. And then no significant deterioration in sexual function or urinary function if you're doing a baseline versus at after getting radiation therapy and local excision. So they found in this study that nearly half of patients with stage T2N0 can actually achieve a PCR just getting radiation therapy alone. Recurrence and survival are similar if you're getting just a TME. These are still stage 1 tumors. And you're still preserving the rectum with minimal deterioration in quality of life. So certainly something to consider. I have to say I have not offered this to a patient and have not seen this discussed in our tumor boards. if you're going to be offering this, just recommend that you make sure you're carefully selecting your patients and somebody who would be very high risk for proctectomy. I think probably right now the standard of care is still proctectomy. And there are other studies that have looked at local excision. I just sort of pull out this one. This is one of the first, and by Dr. Garcia Aguilar. All right, so with our last sort of 10 minutes or so, we'll spend some time talking about non-op management and watching weight, or what are the data to support that. So everyone should be aware, of course, of the initial trial coming out of Brazil from Harugama, published in Annals of Surgery in 2004, operative versus non-operative treatment of stage 0, so clinical complete response, distal rectal cancer following chemoradiation therapy. And so the rationale that they found was that tumor downstaging with pre-op therapy could lead to complete clinical response. They observed that in about 10 to 30% of patients who are treated by radiation therapy alone, and they're calling that stage 0 disease, basically clinical complete response. We all know that surgical resection is associated with significant morbidity and mortality, stoma issues, as the case I presented earlier, and perhaps surgical resection doesn't lead to increased overall and disease-free survival. So some things that I think are interesting to make note of with really all of their trials, pay careful attention to. These are only for distal rectal cancers. So if you are going to do non-operative management, they need to be tumors that you can palpate. That's one of the 3 criteria to establish clinical complete response: endoscopic, digital rectal exam, and MRI. So if you cannot feel it, according to them, that is not something that you should be treating with non-operative management. Another key point, they only do long course radiation therapy. There's no neoadjuvant chemotherapy. So definite differences compared to, I think, what we typically see. So mean follow-up about 57 months. Clinical response, so about 27% of patients had clinical complete response after long course radiation therapy for these distal rectal tumors. And when we look at this overall survival and disease-free survivals in the non-op group, 5-year overall survival 100%, disease-free survival 92%, and no statistical difference in recurrence in mortality, whether or not you're getting non-op management versus surgery. So their conclusions, and this really paved the way for a lot of this, is chemoradiation therapy can lead to significant rates of complete clinical or pathologic response. Clinical complete response, stage 0 disease, associated with excellent and long-term results, irrespective of treatment strategy. And it's all about identifying who's had a clinical complete response. And if you can avoid doing a proctectomy, you can avoid significant morbidity, mortality, stoma construction. So I'll just sort of pull up a couple of other studies that have looked at their experience. So this is an international multicenter registry study, basically pooling together a bunch of centers looking at their data. And so I'll just sort of point out, so there's 880 patients total, about 200 are from Brazil, about 240 are in the Netherlands, and then a smattering of other places. Median follow-up time about 3 years or so. So local regrowth, so these are all patients with clinical complete response and are treated non-operatively. Local regrowth rate, about 24%. About 8% develop distant metastasis. Interestingly, again, we're not talking about TNT with this cohort. Okay, 738 out of 880 are only getting chemoradiation therapy. So again, a little bit of a difference, I think, compared to what we typically see and do here in the US. All right, so some key numbers here. So local regrowth, so 2-year local regrowth rate, about a quarter. 64% diagnosed in the first year, 88% diagnosed in the first 2 years. Local regrowths located in the bowel wall, and 97%. And 78% of patients with local regrowth were able to be salvaged with a TME, and 88% of those had an R0 resection. 3-year rate of distant mets, about 8%. If you had a local regrowth, about 18% had a distant met. So if you have a local regrowth, obviously worse prognostic predictor. 5-year disease-specific survival, about 93%. 5-year overall survival, 85%. With sustained clinical complete response, excellent disease-specific and overall survival. If you have local regrowth, certainly not as good, obviously, but still reasonable. 5-year disease-specific survival, 84%. So, a lot of questions remain about the optimal selection, follow-up protocol, what's the best approach for near complete clinical response, things that they didn't study here. And then I'll just show some data out of Memorial Sloan Kettering with some of their watch and wait results published in JAMA Oncology 2019. Retrospective cohort study. And so they're comparing, in some ways, apples and oranges, because they're looking at 136 patients who had a TME and had a path CR versus about 113 patients who had clinical complete response and then were treated with a watch and wait strategy. So median follow-up about 43 months. So big, retrospective cohort study. So big differences between the two groups. So when I look at this, I'm more just using this to look at numbers again, so we can quote our patients' numbers. So with the watch and wait, local regrowth, 21%. So with the international group, about 25%, this one about 21%. Median time to local regrowth, about 11 months. The majority, so about 72% of patients had regrowth within 12 months. So that first 12 months, certainly the first 2 years, super important time to pay attention for regrowth. 86% of regrowths had an endoluminal component. I think it was 97% in the international cohort. 8% of patients in the watch and wait group developed distant mets, the exact same number as in the international study, versus only 4% in the PCR group. And if you had a local regrowth, again, that's a very poor prognostic indicator. If you had a local regrowth, your rate of distant mets was 36%, compared to only 1% if you had a persistent clinical complete response. 5-year overall survivals and disease-free survivals, good, but not nearly as high as if you had a path CR, right? 73 versus 94, 75 versus 92, 90 versus 98. And whether or not you did induction or consolidation chemo didn't matter. So some of their conclusions, so 82% of patients managed with watch and wait achieved rectal preservation. So that's that 22% local regrowth. All local regrowths detected. And so one of their rationalizations is that the overall survival, although not as good for path CR, is still about 75–80%, which in the context of modern randomized controlled trials is actually pretty appropriate, but not as good as the path CR. Okay, so measure of caution as we weigh the risks of watch and wait for each patient, and really need to risk stratify. So I'll just sort of put up some concluding slides. According to the trials we have, laparoscopic surgery is not non-inferior. Robotic surgery doesn't lead to lower conversion rate. You can consider local excision with chemoradiation therapy for T2 and zeros. Again, all these things are obviously not what we're doing in the real world. And so, discussions at tumor board, super important. For watch and wait, I think these are some important numbers. So if you get total neoadjuvant therapy, maybe 25 to 30%, maybe a little bit more, will have a clinical complete response. About a quarter of those will recur. So 20–25% have local recurrence. About 3/4 of them, so 70–80% of them, can have a curative resection. But a quarter of them will have distant disease. and won't be able to have a local curative resection. So if you do some of the numbers, it's possible, based on the data we have, that only about 5 to 6% of patients might do worse with the watch and wait approach. Of course, there hasn't been a study that's definitively proven that, and there's a lot of ongoing questions that we all have. So what do we do? So locally advanced rectal cancers, chemo, radiation therapy, then chemo. If clinical complete response and they're interested and motivated, then consider watch and wait. What would you do if you're in this situation? I always love asking this to surgeons. If you need a temporary ostomy or you need an APR, and truthfully, I'll be upfront, I would say, yeah, give me a stoma. I don't, I'm stoma marked right now, just in case. Except if I wind up with a stoma, then I would probably not be as happy. A lot of ongoing questions. Certainly something I'm interested in. If you have thoughts, reach out. Happy to answer any questions.
Awesome talk, Dr. Abelson, on a very challenging and very complex topic. A lot to cover there. Thank you for making that easy for us to at least try to understand. A few questions out there. Are there any studies, factors that help identifying patients at risk for local recurrence in the watch and wait strategy?
At risk of local recurrence, not that I'm aware of. I mean, I think probably the bigger question is, are they true clinical complete response and not just a near complete response? So I think maybe that's the real question, is the careful selection. Flat white scar, telangiectasias, no evidence of tumor on MRE, clean digital rectal exam, no nodularity, strict definition for clinical complete response. I think probably the folks who are probably a high percentage of the people who are getting local recurrences, in fact, are probably the near complete responders, perhaps.
So for your near complete response patients in your practice and at Lahey, are you guys giving them 6 to 8 weeks more to kind of give them a chance to declare themselves? Or
yeah, and I think this is where you have your conversation with the patient, right? I mean, with all this, and that's why sort of an upfront point I made is you need to be aware of this as an option, and talk about it with patients, because ultimately they're the ones who are taking on the risk, right? We provide them with whatever counseling and all the data and the numbers that we have. And so we tell them. And so, yeah, if it's someone who's, looking at a permanent colostomy or is terrified of surgery, okay, let's give it 6 weeks, and we'll revisit. Whereas I think somebody who's maybe not as much on the fence, you might just say, okay, based on the data we have, unless you have a clinical complete response, we really shouldn't be doing non-operative management and watch and wait. So even if it's near complete, probably we should just go to surgery.
Yeah. One of the things that I think has been tough has been when you'll see questions about, or like when you have imaging and it says cannot exclude, malignancy, and you don't know what to do with that, and that's a very challenging point at that point. So, but
yeah, absolutely.
Another question we have: the old T3N1 upper rectal cancer scenario. What are people doing?
Great question. Classically, upper rectal cancer, you're not going to be able to palpate, so that it is not someone who you'd be able to use those 3 pillars to say that they've had a clinical complete response, and so you shouldn't be doing watch and wait. So that's what Rodrigo Perez and Habergama would say. Upper rectal cancer surgery, much less morbid than a mid or low rectal cancer. So likely in that situation, non-operative management shouldn't be in the picture. Like I said, some of the earlier data looking at radiation therapy for upper rectal cancer is not as strong as for low rectal cancers. But I would say, at least in our tumor boards, is it something that's below the peritoneal refaction? Can you safely radiate it? If the answer to that is yes, then go for it. We can open it up. Amal, yeah, what's up?
Hey, John, amazing talk. So have you all, in our tumor board, we usually see this, and it comes mostly from oncologists about, and I totally agree with you, where in order for someone to go into watch and wait, you really need to have a clear definition of complete clinical response and the three pillars, endoscopy, your finger, which I think is probably the most important thing, followed by MRI imaging. But they still push for it, like, oh, you know what, should we just put this person on watch and wait when you know that it's going to be easier LAR and just get the patient's sphincter spraying like 100% done. Are you guys facing that? Like, are you seeing that more and more, especially now with, as we're seeing more and more patient with TNT approaches coming into these conferences?
Meaning more and more patients asking for?
Yeah, and oncologists asking for watch and wait for these upper rectal cancers. I'm seeing that, I've had a run of those where I'm like, you know what, my finger is not that long. I'm not going to be able to reach it. And I just tell them there's no data on that. It has to be within the last 6-7 centimeters where I can palpate it, but
right.
Just keep asking for it.
I can't say that in my limited experience and with our tumor boards that we're getting a lot of push from our oncologists to do that. Probably the people who are the most reluctant are going to be the patients to actually undergo surgery and have a temporary stoma, which I get. But I don't think that in our situation, I don't think it's the oncologists who are pushing for it.
Mm-hmm.
Well,
patient. Just to add a quick comment. So amazing data on the TNT and all that stuff. There's a new trial out just very recent. It's called Stellar. So how we talked about Rapido being high risk, low rectal cancer, so M2s and the T4s and all of that. Stellar looks at all just basically this mid and low rectal, all incoming locally advanced rectal cancers. It's out of China. It just got published. I can send the link in the chat.
Yeah, that'd be great.
And it's I think with that now you also have how like we were using Rapido and the Project 23 to basically do TNT for everyone. This basically answers that if you have a local advanced low risk in the second or the third portion of the rectum, you can just safely do a TNT with good outcomes.
Great. Yeah, thank you.
So,
other questions?
Dr. Abelson, if I can pick your brain, I think one of the more interesting parts of this is, minimally invasive surgery is like a pillar, kind of the corner, whatever you want to say, a cornerstone of what we do now with colorectal surgery. And when you're looking at these well done randomized controlled trials, as you're saying, they're not inferior, if I can use the double negative again, how does that translate? I mean, I know in what I plan for my practice, but how does that translate into your practice or your mentor's practice or, even the senior partner's practice? I have to imagine it's still MIS over anything.
Yeah, I think so. And I think this is where no matter what we're doing in terms of new technology, just always sort of coming back to, are we make sure we're not hurting the patient, looking at your own results, your own outcome, right? So when you get your path report for your rectal cancer studies, what's your TME looking like? What are your margins looking like? And so you can have bad path outcomes if it's open, if it's lap, if it's robotic, if you're doing TA, TME, so I think just on an individual level, I think just making sure you're doing your own quality control and doing what you feel comfortable with. So if you feel very comfortable doing a straight lap proctectomy, then you were like just going to try and do it open, then maybe that wouldn't be as good. If you're trained in something well, then do that thing well. And I think that's the answer.
Thank you very much.
Any other questions for Dr. Abelson? Awesome. Well, we'll be respectful of everybody's time in the evening tonight. Thank you to everyone for joining us and Dr. Abelson for a great talk. Hopefully we'll see everybody next weekend in Tampa. Otherwise, another shout out to applicants and fellows for next year. Please apply to be on the education board next year to kind of help run this. If you're a fellow going into fellowship or a resident right now going into fellowship next year, please send your application to us. We'd love to have you join us. And with that, thank you everyone for joining us, and we'll see you in a few weeks.
Great. Take care.